We'll give everybody just a minute to join and we'll get started. All right, good afternoon. Thank you for joining us for Astardi Medical's webinar presented by Dr. Bill Hay on neonatal hyperglycemia, perhaps not a benign disorder. I'm Tammy Jansen, co-founder and CFO of Astardi Medical. For those of you who don't know us, Astardi Medical is a precision nutrition company providing digital solutions to support nutrition and feeding practices for preterm infants in the NICU. We've been hosting a series of educational webinars, all focused on the growth and development of preterm infants and the importance of feeding, nutrition, and gut health. This is a look at our past webinars. You can view any of them on demand by visiting our website at astardimedical.com. This is a glimpse at our current incredible lineup of upcoming speakers. You can also find the details for these upcoming webinars on our website. Please mark your calendars and join us for our next webinar on May 13th for a presentation by Dr. Henry Lee on data and quality improvement to address disparities in neonatal care and outcomes. Dr. Lee is Associate Professor of Pediatrics and Neonatology at Stanford University. He serves as Chief Medical Officer of the California Perinatal Quality Care Collaborative, an organization of 139 NICUs committed to improving the quality of care for California's mothers and most vulnerable infants. So please watch for the invitation to Dr. Lee's webinar in your inbox. I'm now pleased to introduce our esteemed presenter and expert in the field of neonatal feeding and nutrition, Dr. Bill Hay. Dr. Hay is retired professor of pediatrics neonatology at the University of Colorado. In addition to practicing neonatology over his career, Dr. Hay conducted a wide variety of research projects focused on maternal nutrition, placental nutrient transport, fetal physiology, and fetal and neonatal nutrition and metabolism. A major emphasis of his clinical research focused on intravenous nutrition in the preterm infant and how to optimize nutrition to prevent postnatal growth faltering. We've had the great fortune of working with Dr. Hay for almost 2 years now, and it's truly been a joy and a delight. We'll have time for Q&A at the end of Dr. Hay's presentation. Please post your questions at any time throughout the presentation in the chat box on the right side of your screen. And I'll now turn it over to you, Dr. Hay.
There we are, and I hope you can all see the figures and hear me. And I'll try to get through this quickly to allow for some questions. If I go too fast, don't forget, as Tammy said, you can go to the website and this talk plus all of those that have been given before will be ready for you. So I'm going to talk about neonatal hyperglycemia, and my screen won't advance, so how do I do that?
Computer. Great.
There we go. So a couple of disclosures, and you can see them there. None of these had anything to do with the preparation of this presentation. So first, what is neonatal hyperglycemia? Most of the textbooks have arbitrarily defined it as greater than 125 milligrams per deciliter or 7 millimoles per liter. I think most of the neonatologists I've worked with over the years would say it's not clinically significant until greater than 180 milligrams per deciliter or greater than 10 millimoles per liter. But there's no data to support either. These are arbitrary definitions. So why should we be concerned about hyperglycemia in newborn infants? This begins with what's changed in medical practice over the last 20 or 30 years, in large part positive trend to start parenteral nutrition on day 1 of life in very preterm infants, and most are doing so by day 2. And when we do that, it would be nice if we gave a balanced mix of intravenous nutrients, but we don't. This is nice data that came from Dr. Vasu and her colleagues with Nina Modi in London, where they very clearly show that early carbohydrate intake and total carbohydrate intake over the entire period of intensive care is going to lead to hyperglycemia, because this is excess carbohydrate intake, more than the baby needs in terms of amount of carbohydrate for energy metabolism. And the hyperglycemia is clearly going to be augmented by the early and total lipid intake, and we'll get to that a little later on. The problem with excess dextrose or glucose infusion is that we usually give too much. The standard approach to IV dextrose is to, and this is used and recommended by most, and it's been common practice, is to start relatively high at 6 to 8 milligrams per minute per kilogram, beginning pretty close to birth when the baby gets to the neonatal intensive care unit. And then over several days, but really more recently over a shorter period, increasing to as much as 12 to 14 milligrams per minute per kilogram for full intravenous nutrition, trying to get up to a pretty high calorie intake. And this is done sort of reflexively. It's done without considering the normal physiology of these babies, their degree of illness, or other pathophysiology that might augment glucose production and hyperglycemia. And the perfect example of that comes from Norway, this nice study by Stensvold and colleagues, where they compared two periods, an older period, 2002 to 2005, and a recent period of 2006 to 2011, showing a significant advancement of carbohydrate intake, glucose infusion rate, and the incidence of severe hyperglycemia, which they defined as greater than 12 millimolar or 216 milligrams per deciliter, which would fit almost everybody's diagnosis of hyperglycemia, severe hyperglycemia. And it also was noted that this, and I'll come back to this, that this was associated with, whether a marker or cause is uncertain, with an increased death risk. And this higher infusion rate of dextrose is compounding other risks for hyperglycemia in neonates, which we all know about, but we don't often think about them. Preterm birth by itself and low birth weight and intrauterine growth restriction all produce, these babies all produce less insulin secretion, especially at the lower gestational ages. And the IUGR fetuses, and then therefore the neonates, have fewer pancreatic beta cells and total insulin secretion capacity. We don't feed them enterally as much as maybe we could, and this diminishes incretins or incretins that promote insulin secretion, and those are already reduced in low birth weight infants. There are many problems that these babies have, suspected or actual sepsis and other stressful conditions, and these enhance endogenous catecholamine and glucocorticoid secretions, which break down glycogen and produce more glucose. We give catecholamine infusions. We also give glucocorticoids, hydrocortisone, and these augment glucose production. And then we use intravenous lipid fairly early, and recent studies showing that maybe that's a good thing to do for total calorie intake and brain growth. But that's obviously going to interfere with glucose utilization and increased production. I'll come back to that. And then we have persistent hepatic glucose production, augmented by lipid infusion. It's certainly characteristic of infants who had intrauterine growth restriction and in preemies who have less insulin, so they do not block glucose production. Glucose production really is nature's way of ensuring sufficient glucose for brain and cardiac function right after birth. And even as early as 28 weeks, in a nice study by Agneta Sunahag, preterm infants of this gestational age will continue to produce 2 to 3 milligrams per minute per kilogram. They may need as high as 7 to 9 for glucose utilization rate for the brain and the heart. And the same pattern persists throughout the later part of gestation, even up through term infants. So what happens when more dextrose is infused to these infants? This is a Sunahag's study that I mentioned, and you can see here that the rate of gluconeogenesis simply continues, and therefore plasma glucose concentration will be directly related to glucose infusion rate, and that's a nice positive slope. This was one simple study, but it's been confirmed many times. And the risk for hyperglycemia from glucose production is further compounded by glucagon secretion. I mentioned this. It promotes glycogenolysis by activating glycogen phosphorylase, and gluconeogenesis by activating PEPCK, the first enzyme in the gluconeogenic pathway. And that happens especially when insulin is low, which it generally is in these babies. And then we infuse, as I said, intravenous lipid infusion. The glycerol within the lipid infusion fuels gluconeogenesis. Agneta Sunahag's studies showed this very clearly. There are free fatty acid metabolic products in the liver, ATP, acetyl-CoA, NADH, that all activate enzymes in the gluconeogenic pathway. Mike Narkowitz and Jean Girard showed this very clearly. And the fatty acids themselves limit glucose oxidation competitively, just one carbon substituting for another carbon. And then intermittent hypoxic ischemic conditions are common in preterm birth, and these lead to insufficient oxygenation that leads to increased counter-regulatory hormones that produce hyperglycemia. Paul Lauzon's created this figure showing decreased oxygen content, increasing norepinephrine production, and O2 content going down, increasing cortisol production. So hypoxia ischemic episodes increase catecholamines and cortisol, and these clearly increase glycogen breakdown. They decrease insulin secretion and insulin action, and they increase protein breakdown, providing substrates for gluconeogenesis. And so this is not a good situation if you're trying to reduce hyperglycemia. And then, as I said, we infuse catecholamines. In this case, a nice study from Istvan Siri showing that epinephrine infusions markedly increase glucose concentrations over 150 milligrams over the first 24 hours of an epinephrine infusion. Now, they didn't see hyperglycemia with dopamine, but many of us have. I suspect because when you infuse dopamine, if you do it at a high enough concentration, producing a high enough concentration, that seems to augment endogenous catecholamine production. And so you actually might see this with prolonged use or high dose dopamine infusion as well. And just to show you how dramatic this was a study in fetal sheep from Abby Foden showing the impact of adrenaline suppression of glucose-induced insulin secretion. And it's quite profound. So here's increasing plasma glucose, and there's increasing plasma insulin in response, and that's a huge, steep increase without adrenaline. But when adrenaline was infused, you cut that by 2/3, inhibiting insulin secretion. So catecholamines do a good job, if you will, of reducing insulin secretion and therefore leading to enhanced glucose production by not suppressing glucose production by the liver and not stimulating glucose utilization peripherally. Now, if you keep your TPN going with high glucose infusion rates, dextrose infusion rates, and produce hyperglycemia, and you keep going for quite a while, you end up making hyperglycemia persist and maybe even get worse. And this is a study showing this experimentally in fetal sheep that we did a long time ago with a group from UCLA, Sharinda Vaskar. And you can see GLUT1, which is the ubiquitous glucose transporter in the brain, in the liver, in skeletal muscle, the myocardium, and adipose tissue, over long periods actually are reduced. GLUT1 is reduced. And GLUT4, the insulin-sensitive transporter, similarly, myocardium, skeletal muscle, and adipose tissue, all tending to go down. So that over time, you're going to reduce even in the utilization of glucose, even in the presence of hyperglycemia that develops from this persistent glucose production and glucose lack of glucose utilization. And this is a study from Burns Group in Houston, which showed the same thing in piglets. So not the fetus, but piglets. And these are normal term piglets that were fed parenterally or enterally. And you can see increased insulin and glucose area under curves with persistent TPN. They weren't exactly hyperglycemic when they started, but this tended to produce hyperglycemia. So clearly what's developing here with the persistent intravenous feeding is insulin resistance and glucose intolerance. And as I pointed out, this does occur by downregulation of the glucose transporters. You're reducing insulin effect peripherally and glucose utilization. And you also can reduce by persistent hyperglycemia, reduced proliferating insulin-producing pancreatic beta cells. Again, the same group from Doug Byrne, decreased insulin-positive cells. There that goes down. That's enteral and that's parenteral. and the decreased insulin cells proliferating beta cells. So you not only suppress the number of insulin positive cells, you're reducing their capacity for proliferation, setting them up for less insulin secretion and the risk then of persistent hyperglycemia. And then there's also reduced relative abundance and phosphorylation of proteins in, for example, liver and skeletal muscle. Here's liver in the top and muscle at the bottom. And you can see in every one of these situations, insulin receptor substrate, and PI3 kinase, the enzyme within the liver, within the cells in the liver and muscle that activate glucose utilization directly. So clearly, persistent hyperglycemia suppresses the capacity for glucose utilization and the effect of insulin to stimulate glucose utilization. Hyperglycemia is especially a problem in IUGR infants. I've mentioned that, and this is data just to support that point. Here's data from human intrauterine growth restricted fetuses at the time of delivery. They had normal fetuses and normal IUGR fetuses, when that's same glucose concentrations, but then they gave them a stimulation of glucose. This was a bolus of glucose, and you can see that the normal fetuses hugely increased their insulin production and our glucose concentrations, but this was suppressed in the IUGR infants, so they did not produce as much insulin at all. And that's very nicely shown in the fetal sheep model. These are data from Sean Limison. This is a normal fetus in response to a hyperglycemic glucose infusion, showing insulin secretion going up and a nice plateau over the 2 hours of the glucose infusion. But in the IUGR fetus, this was suppressed. These are fetal sheep. So the slow rate of rise of insulin secretion and lower concentrations. This is due to decreased pancreatic islet insulin content, markedly reduced with the growth-restricted fetuses, and that's due to decreased beta cell mitosis. There's a lot of physiology about how that comes about, but that's the end result. And then Stephanie Weslowski showed very nicely that IUGR infants also have increased glucose production. This is not due to hypoxia, it's due to hepatic insulin resistance. Here's glucose production. In the basal state, it's higher in IUGR fetuses. When those are given insulin, that does not suppress glucose production like it does in control normal fetuses. And here's the MRA for the PepCK enzyme, and the protein would show exactly the same. It's much higher in basal conditions and not suppressed by insulin when insulin actually is given. So infusion of insulin does not reduce the capacity for insulin to support glucose, suppress glucose production. So neonatal hyperglycemia is common. It's largely due to excess dextrose infusion, compounding many conditions that increase risks of hyperglycemia, and it gets worse the longer it persists. But is it a problem? Well, here's a study in adults, and there were a number of studies that came out quite a few years ago in intensive care units showing that those adults who were hyperglycemic, and these were infant adults that were in intensive care and were on intravenous feedings, they had increased morbidity and mortality, impaired immunity, increased infection, poor wound healing, suppressed autophagy, cellular repair and organ recovery, and loss of skeletal and cardiac muscle. So evidence for such problems in hyperglycemic newborn infants is lacking or uncertain, but probably because we simply haven't looked for it. But if we did look for it, what would we see? Well, we see all kinds of problems, and some of these are new and some of these are long-standing. This happens when we really exceed glucose utilization capacity. For example, when we get up above 10 to 14 milligrams per kilo per minute. Old studies were worried about hyperosmolality, polyuria, dehydration, acidosis, electrolyte abnormalities, and even intracranial hemorrhage. We don't see much of these anymore because we're controlling glucose and we're not getting it to those extremely high levels. But the intracranial hemorrhage has been interesting because this almost always is accidental. For example, the pharmacist makes up D7.5 by using D75 and adding that to water. But if by accident somebody infuses the D75, well, you're going to see glucose concentrations of 2,000 to 3,000 milligrams per deciliter, and that will produce intracranial hemorrhage. Excess glucose will increase energy expenditure by producing fat through synthetic mechanisms, and that's very energy expensive. That increases oxygen consumption, producing relative hypoxia. It also increases carbon dioxide production, which can complicate babies with respiratory distress by making them tachypnic. It increases fat deposition and excess of lean mass. It increases fatty infiltration of heart and liver, and it will increase cardiac septal hypertrophy and right ventricular dysfunction. These are problems we see in very severely abnormal infants of diabetic mothers, so there's no point really in trying to recapitulate these in normal preterm babies. There are cellular mechanisms that account for some of these severe disorders. These are due to mitochondrial stress from the excess carbon load. This bad triad of cortisol and catecholamine levels, hyperglycemia from excess infusion and production, and all of the other mechanisms we've been talking about, and then increased insulin, and sometimes insulin when it's been given to try to control hyperglycemia. Those all produce excess cellular glucose uptake. This leads to cellular dysfunction. All kinds of these are documented in this figure from this nice review from Picard and Nature Review Endocrinology. But one of the biggest and most common is increased reactive oxygen species production. This leads to systemic inflammation. And what are some of the consequences? Well, here's one, hepatic and systemic inflammatory proteins. Every one of these on the y-axis here is an inflammatory protein, and they're all markedly increased in babies on TPN. This case is a study of piglets. This has been recapitulated in human infants, not as high at all in the normal range in those piglets and like babies on enteral feeding. And this is just 4 of them to show TNF alpha, IL-6, MPO, and P-junk, all increase 50 to more percent with the hyperglycemic condition, producing both local cellular and systemic inflammation. There's some other interesting things that have been coming along more recently, and that's the problem with more infections in patients on intravenous feeding, many of which are hyperglycemic that I've mentioned already. So excess glucose has been associated with increased bacterial infections. That's because in vitro and in animal studies, it was very nicely shown that bacteria thrive with excess glucose, leading to worse infections and death of the organism. And that might occur in the NICU, where bacterial infections are more common as causes of serious sepsis. Viruses, interestingly, for the most part, do the opposite. So maybe if an infant has a proven virus infection, glucose might not be as bad. Well, maybe. Here's a nice study showing that might be too simplistic. Too much glucose also can make viral infections worse by promoting inflammatory cytokines. So excess glucose into the cells, cytokines are produced. Guess what? Lung injury. So maybe pneumonia might get worse if we happen to have a viral infection producing it if the babies are hyperglycemic. And that's because blood glucose levels correlated very tightly with levels of inflammatory cytokines. And then blood glucose, not enteral glucose in the gut, but blood glucose, and particularly when excessively increased concentrations of blood glucose, promote parasitism by compromising gut barrier function. So here's our gut barrier, and we see that blood glucose, when it's very high, can compromise the barrier function, promoting influx into the bloodstream of pathogenic bacteria and microbial products. So you might think twice about a baby who's hyperglycemic and then develops necrotizing enterocolitis with systemic sepsis, where there might be a direct link. There are other organs that are affected, and one that we've known about for years is the eye. Infants with ROP have higher glucose concentrations than infants without ROP. That's about a doubling of the risk of ROP with high glucose concentrations. And this occurs at two different periods, and it augments the damage to the retinal vasculature that high PO2s have during the first 2 to 3, 4 days of life. But and that's when maximum PaO2s are very high. But days 5, 9, 13, up to 17, there's persistent problems with hyperglycemia leading to retinopathy of prematurity. So it's not just oxygen and hyperglycemia complicating the oxygen damage, but hyperglycemia itself. Insulin could make this worse by promoting glucose oxidation and reactive oxygen species production, but infusion of amino acids and protein with sufficient energy might limit this by promoting insulin-like growth factor 1, IGF-1 production, and Hellstrom has shown that, and that might be protective against ROP. So higher protein intake, lower glucose intake, a good start to what we might do about this problem. A lot of people have been very concerned over many years now about hypoglycemia. That's at the lower bar here, lower part of this figure, compromising hypoxic ischemic encephalopathy. And sure, with unfavorable outcomes are more common with hypoglycemia over the first 12 hours of life than without hypoglycemia. But look what happens with hyperglycemia. Much worse outcomes, and they get even more complicated with unfavorable outcomes with hyperglycemia, several fold more than with hypoglycemia. So hyperglycemia at every time point in this particular study, this was the CoolCap study, that produced more unfavorable outcomes when there was hypoxic ischemic encephalopathy. And here's just another study showing the same thing, that higher blood glucose concentrations are associated with worse motor outcomes and death in babies that had asphyxia or hypoxic ischemic injuries. That's borderline significant, but a pretty good bulk increase in these severe adverse outcomes with hyperglycemia. We also know from animal studies primarily that chronic maternal and thus fetal hyperglycemia leads to adverse neuronal development. This is just one of many studies where maternal and thus fetal hyperglycemia had dramatic adverse effects on neurodevelopment. So here's hyperglycemia, and here's the number of dendritic spines in these brains of these animals. And here's synaptophysin, a protein that is responsible for synapse formation. And you can see that the hyperglycemia in black markedly in the white bars, markedly suppresses the number of dendritic spines and reduces synaptophysin. So you're going to have poor formation of synapses. The dendritic spines are reduced, so you're going to just not really be able to produce as normal a connectivity pattern in the brain. Pretty nasty adverse effect of hyperglycemia in these fetal animals. Chronic neonatal hyperglycemia also leads to adverse neuronal development, growth failure, and risk of death. So here's one study. These were rat pups, and they were given subcutaneous dextrose for 11 days, and increasing with the severity of hyperglycemia. These are very high doses for these animals. Decreased neuronal density, markedly reduced, increased oxidant status, increased significantly, decreased antioxidant status, dramatically reduced. So these effects of hyperglycemia on the developing brain in newborns don't look very supportive of that as a benign condition. These are studies from Sarah Rammel's group in Minnesota, when they looked at infants who had 5+ days versus 0 days of hyperglycemia, increasing risk of Bailey cognition insufficiency, Bailey language insufficiency, and Bailey motor insufficiency. These models from 1 to 3 show increasing severity of illness and worse protein and energy intakes. So clearly, persistent hyperglycemia in babies leads to reduced cognitive outcomes. And Sarah's study also showed that increasing risk of diminished growth occurred both in terms of length and adiposity with persistent hyperglycemia. That's fat-free mass and that's fat mass, both reduced when there were more than 5 days of persistent hyperglycemia. So maybe this is because of downregulation of the growth hormone axis, but they also show, as I said before, the cognitive deficits that occur as well. Cynthia Blanco did a nice study in preterm baboons, and she showed progressively lower probability of survival with prolonged severe hyperglycemia. This did not appear to be due to oxygenation or ventilation indices. This was a hyperglycemia induced condition. And then getting back to humans from baboons, Stensvold again showed that death was much more common in extremely low birth weight infants when they were on parenteral nutrition with persistent hyperglycemia. So this is hyperglycemia at 12 hours. This is hyperglycemia at 7 days. Early enhanced parenteral nutrition itself was not predictive of mortality, but hyperglycemia during the first week, hyperglycemia during the first week of life produced severe adverse effects on predicting mortality. This was independent of risk factors except for gestational age and clinical risk index. So yes, the sickest babies and those most preterm were at higher risk of dying, but really it was those with severe hyperglycemia that had the worst risk of death from persistent hyperglycemia. So neonatal hyperglycemia is common. It's largely due to excess dextrose infusion, compounding many conditions that increase risk of hyperglycemia. It gets worse the longer it persists, and it is pathological, injurious, and perhaps even lethal. So how should we prevent it and treat it? Well, along came a study of looking at tight glucose control by infusing insulin, either therapeutically or prophylactically. And there was initial success in these adult studies. Reducing all of those things that we showed before were adversely affected by hyperglycemia. So reducing by insulin infusion, hyperglycemia, reduced morbidity and mortality, improved metabolic status, energy expenditure, improved cardiovascular status, improved systemic and regional delivery of oxygen, improved immunity, reduced infections, better wound healing, improved nitrogen balance. But that was the first study. A subsequent trial, a set of trials in 42 hospitals in 4 countries failed to demonstrate persistence of these benefits from tight glucose control, and actually demonstrated significant excess mortality when the insulin was infused therapeutically to try to get glucoses into the conventional range. So did insulin actually make things worse? Well, it might. Kathy Beardsall in the United Kingdom has done quite a few studies. This is the outcome of the Nurture trial, where they used prophylactic insulin infusion to try to reduce hyperglycemia. So here's early insulin, and this is glucose concentration. Those are the controls that are hyperglycemic. There's the insulin prophylactic infusion group. So yes, prophylactic insulin lowered glucose concentrations. Same thing shown here, but look, here's an increased risk, several-fold increase in the risk of developing hypoglycemia. Now, it's not a lot of cases, and they didn't really get down to levels where the hypoglycemia was producing seizures or coma or apnea with profound muscle weakness. But that basically stopped the use of prophylactic insulin infusion because of that concern. And that's been observed in other studies, particularly from the Auckland group. Another study, this is from the Auckland group, Jane Allsweiler's study, looked at tight glycemic control with insulin in hyperglycemic preterm infants. And you can see in this blue box up here that after a number of days of randomization of treating or not treating hyperglycemia with insulin, there was a suppression of growth. Maybe not big, just like the hypoglycemia may not be severe, but the balance of risks and benefits of insulin treatment in hyperglycemic preterm neonates remains uncertain from these clinical studies in these babies. So tight glucose control using insulin to prevent or treat, we should be cautious and look at limitations. Insulin increases the risk of hypoglycemia. That was the Nurture trial. Insulin actually makes the babies fatter. Insulin promotes fatty infiltration of heart and liver, and those are inflammatory conditions, and that can lead to systemic inflammation. Insulin increases mitochondrial carbon load, reactive oxygen species production, oxidative injury, and inflammation locally and systemically. Insulin, when it's infused, does not promote glucose uptake or utilization by the brain or enhance neuronal growth or dendritic development, so it's wasted on the brain approach. Insulin can lower plasma essential amino acids, and this will limit protein synthesis unless you infuse amino acids at the same time, and that should be monitored, but we don't do that very much. And then there's negative feedback mechanisms that the Auckland group showed that I've already shown a picture of that might shorten leg length, in other words, actually reduce the capacity for growth, and that fits also with persistent hyperglycemia that Sarah Rammel's study showed. So insulin just doesn't work as a growth hormone to augment growth when it's given in excess. What do we do about the most severe cases of neonatal hyperglycemia? Well, there are standard approaches. I just put the standard one that came out of my group, low-dose insulin infusion. And this can be used when decreasing glucose infusion rate and other measures don't work, and the glucose concentration in the plasma remains very high. But how high is too high is controversial. Some say, well, we ought to treat with insulin when the babies have greater than 180 milligrams per deciliter of glucose. And others say, I'm not that worried, maybe 250 to 300. There's no data to support either of these really, but there is a risk when we give insulin that we can lower glucose concentrations precipitously. In this case, a standard approach of insulin in this hyperglycemic baby markedly dropped the glucose concentration in only an hour. High risk of hypoglycemia when we infuse it at higher concentrations like this. There are a couple studies that looked at this, insulin infusion versus reduced glucose infusion rate to treat hyperglycemia in very small babies. This was reviewed in the Cochrane Library, but this was the only study that was reviewed. There was only one, Meets et al. In Biology of the Neonate, clear back in 1998. And when they used insulin versus simply lowering the glucose infusion rate, there were no differences in all of the age weight groups on death, sepsis, ROP, NEC, intracranial hemorrhage, chronic lung disease, NICU days, or growth. And then again, back to Norway and Stensvold's group published in 2018, lower, earlier glucose infusion rates reduced the prevalence of severe hyperglycemia by almost half, 48 to 23%, insulin use, 39 to 16%, and mortality, 26 to 10%. So concluding from these two clinical studies, it appears to be safer to just start with and use lower glucose infusion rates. And in preterm infants on early parenteral nutrition, you could simply use more amino acids. This is Patty Thurin's study, where she gave 3 grams versus 1 gram of parenteral amino acid infusion. And these are the insulin concentrations. Scott Denny's group did exactly the same thing and found the same results. Amino acids stimulate insulin secretion, and that's going to be good for suppressing glucose production and enhancing glucose utilization. And this is an Italian group. They did 2 different studies. Those are the references, but in this one study, they aimed at 4 grams per kilo per day of amino acids. They didn't quite get there, but the control group only got 2.5 grams per kilo per day, and they used standard amino acid infusion. And what they found was very clearly in the higher amino acid infused group, there were lower glucose concentrations on average. And this is over 10 days. and there were many fewer cases of hyperglycemia. So really a benefit from early amino acid infusion. And then we could reduce our lipid infusions. Again, going back to nicotinamide, this is gluconeogenesis when glucose plus amino acids are supplemented with intravenous lipid, a much higher rate of gluconeogenesis. So if you stop the intralipid infusion, you would lower your gluconeogenic rate and reduce, therefore, glucose production. You could also use earlier enteral feeding. I mentioned this before. This increases incretins, GLP-1, glucagon-like peptide 1 and glucagon-like peptide 2. These stimulate endogenous insulin secretion. There it is, feeding, post, and fasting, small or large feedings. It really didn't matter. Clearly, the enteral feedings are going to enhance insulin production by stimulating these two proteins. There's another advantage of enteral feeding with milk. Milk has lactose in it, and lactase activity is increased when we feed milk. The lactose hydrolyzes is hydrolyzed by the lactase to glucose and galactose. Because you're splitting glucose off from galactose, you produce a slower rise in plasma glucose. Galactose itself is first passed cleared from the portal vein by the liver, deposited in glycogen, and then slowly released into the circulation as glucose between meals. And galactose by itself does not stimulate pancreatic.
Hey, Dr. Hay, your audio has gone very quiet. No, we can hear you, but it's much quieter than it was before.
I haven't done anything.
So okay.
I'll talk as loud as I can. So caution, I've talked about the risks of hyperglycemia, but don't overinterpret. Just as with hypoglycemia, there's large variation among normal infants that includes the potentially harmful ranges of hyperglycemia. And the evidence that any one high glucose value or range of values of high values or any duration of high values or fluctuations in high values can cause permanent injury is limited and uncertain. So as with hypoglycemia, it just makes common sense to avoid and reduce extremes. Keep things as close to normal as possible, as much of the time as possible. I show you the ranges in the normal preterm infant. Well, these are normal human fetuses. And I see no reason not to use these as our normal ranges for preterm infants. A lower value of 3 millimolar, 54 milligrams per deciliter, a higher value limit of 6 millimolar, 108 milligrams per deciliter. How should we keep babies in this so-called normal range of glucose concentrations? Well, frequent blood sampling to measure glucose, but that's difficult to do. So I assume many people are starting to look at continuous subcutaneous glucose analyzers, continuous glucose monitoring. This is an example of simply one baby over a 24-hour period, and it's a preterm baby. And you can see this is the upper range of glucose concentrations I would call normal. So that's greater than 6, anything above that red line is 6 millimoles per liter. And you can see over this 24-hour period, most of the glucose values continuously are above 108 milligrams per deciliter, 6 millimoles per liter. So you could use continuous glucose monitoring to help adjust by various treatments glucose concentrations into the normal range. I'll let you read this particular nice study of glycemic control in the ICU. It referred to adults and older children, but it certainly applies to preterm babies as well. Hyperglycemia is at the center of all kinds of problems that lead to worse hyperglycemia and making this a significant clinical problem. So, summary. First, start at lower IV dextrose infusion rates, 4 to 5 milligrams per kilo per minute in very preterm infants, 3 to 4 milligrams maybe per kilo per minute in late preterm infants. With hyperglycemia, when it's high and you want to get rid of it, start by reducing your IV dextrose infusion rate. For example, if you're up above 8, decreased down to 8 milligrams per kilo per minute, then 6, then 4, even to 2. But then when you get down to these lower rates, your infusion rate of total fluids is low, so you can use a gastric infusion of sterile water to maintain total water intake. And we've done that many times successfully. You have to remember that organs, including the brain, take up glucose according to the plasma concentration. That's not because of the glucose infusion rate, that's the plasma concentration. So if these babies have high glucoses, they're getting glucose into their cells, and that's independent of their infusion rate at some point. We can normalize physiology, especially oxygenation, with good medical care, reduce endogenous catecholamine and cortisol secretions, and we can reduce the treatments with catecholamines and glucocorticoids. We can reduce lipid infusion. It works, although not a large immediate effect. We can increase IV amino acid infusion rates, and we can start enteral feedings earlier and advance faster. These increase insulin secretion. Thank you very much. Those are my favorite babies I've worked with over many, many years, and I look forward to answering, or at least trying to answer some of your questions. And I apologize if my sound recording is down. I haven't done anything, so we'll see how it works. So I'll stop sharing, and Tammy can take over from here.
All right. Thank you, Dr. Hay. Hopefully you lost your sound a little bit in the early beginning, but it bounced right back. So I'm not sure, what the issue is, but we've got some questions for you. How low do you let the GIR go with hyperglycemia?
Good. I just answered that one already with that last figure. So preemptively, that was a good question. So we can go down as low as 2 to 4, but as I pointed out, you're going to have a very low glucose infusion rate at that point. It's tough to get down below D5. Some people have used D2.5, but you're going to need to add some sterile water to produce normal fluid infusion rates. And that works very nicely, gastric infusion of water. So you can go down to very low values, and you still will have plenty of glucose in the plasma to support brain and heart function.
Okay. Express study from Sweden demonstrate later hyperglycemia first month in extremely preterm infants on exclusive enteral nutrition. I don't think most of us even look for Uh-oh, we lost Bill. Sorry, everybody. We'll give Dr. Hay a minute to see if he can call back in.
Join us again.
Sorry, everybody, if you can just hang in there with us for a minute, we'll see if we can get Dr. Hay back on the line.
A minute.
Okay, great. There he is.
Well, I kept seeing myself and hearing myself, but I couldn't see Tammy, or he wasn't moving. So, but if we have a few minutes, let's continue on with the questions.
Okay, your audio is much better now too. Okay, so I'll ask this question again. Express study from Sweden demonstrate later hyperglycemia first month in extremely preterm infants on exclusive enteral nutrition. I don't think most of us even look for hyperglycemia past the first week or so. Very low birth weight reaches all enteral nutrition. Please comment on physiology and, I'm so sorry. And is this morbid?
Well, I know the study, and I was surprised too. And I think the answer is quite correct, or quite real. But the problem is quite real, that we simply don't look for persistent hyperglycemia past the first week to 10 days of life. But I suspect this has a lot to do with just total excess carbohydrate intake. And we do supplement with fortifiers, perhaps more than we need to. The fortifiers have never been adjusted in terms of their carbohydrate and lipid content. We were using them primarily to support protein intake. And it might just be that we're giving way too much carbohydrate and excess lipid that is producing excess glucose concentrations or higher glucose concentrations. And then some babies are going to have just slower development of insulin secretion capacity. And I suspect if they were looked at, that's what you would find as well as persistent excess carbohydrate intake.
Okay. International REACT study using CGM reduced both hypoglycemic and hyperglycemia episodes versus traditionally treated infants. Do you see a potential role for CGM in the NICU, or is it going to remain a research tool?
Well, if they get cheaper, I would expect that they'll be used widely, just like pulse oximetry was. So I think at this stage, we need more information. In other words, when you find abnormal values, both low and high by CGM, is that just more of unknown effects? We still are going to need research to sort out. The Auckland group did show that there was not a lot of adverse outcomes when they looked at the glucose concentrations that were lower by CGM, but no one's really looked at the area above the curve with hyperglycemia. So I suspect that we'll start from going from research to clinical practice, just like we did with pulse oximetry, as these instruments become cheaper. They are very expensive at this point.
Okay. Does hyperglycemia cause hypertriglyceridemia like in adult diabetes? And if so, how?
Well, sure it can, but that's if there's no insulin around. Insulin plus glucose promote fatty acid and glycerol production of triglycerides and fat. And that actually should be beneficial, unless, of course, you don't want fat. But it certainly might help with lowering glucose concentrations eventually. So I think there are cellular mechanisms that will account for that problem.
Is there a known neonatal sequelae if GIR is less than 4, but the baby's serum glucose are normal in HIE baby who is on restricted TFI?
As far as I know, it's not the glucose infusion rate that matters. It's the plasma concentration of glucose. And both low and high glucose concentrations have worsened or have been associated with worse hypoxic ischemic brain injury. So I think the key here is to, and this may be where CGM would have its particular balance, is to try to get very quickly your glucose concentrations into that normal range between 3 and 6 millimolar.
Can you give your thoughts on insulin infusion to promote glucose tolerance in the very sick premature infant on pressors during the first week of life?
Well, if you want to get rid of the glucose, the high glucose concentrations, and you've tried to lower your glucose infusion rate, you've tried to get rid of infusing catecholamines, you've tried to reduce hypoxia and make the baby normoxic. So you go through all of those steps to normalize physiology, reduce the infusion of catecholamines and glucocorticoids and lipids that promote hyperglycemia. And your glucose concentration remains very high. Then I gave you a recipe for infusing insulin. But again, that would be another situation where you might see very rapid development of hypoglycemia. So monitoring those babies either with CGM or very frequent 15 to 30 minute to 1 hour glucose blood plasma glucose measurements would be very valuable.
Okay. If you get to a point of starting insulin, is the preference for a drip versus single dose? And if a drip, how long do you give the infusion before titrating up if no improvement in hyperglycemia to avoid swings in glucose concentrations?
Most of the time, it's a small bolus followed by a constant infusion of insulin. just giving a single bolus, you will get a fall in glucose, but then you will have a response of glucose production again. So the best thing is to try to get the baby on a constant infusion and then slowly titrate down. And you can use whatever any approach you want, but generally you set a threshold value for hyperglycemia that you want to get below, and as long as you're below that, you continue to slowly reduce your glucose and your insulin infusion rate. How fast do you go? Well, from diabetic studies, going more than 25% in 2 to 3 hours is relatively fast. That may lead to, faster than that might lead to cellular fluid shifts and salt shifts that could cause cellular injury. But frankly, I don't know studies that actually have done that very carefully.
Okay. In the situation of hyperglycemia, how do you prevent the infant from becoming catabolic?
Infuse in amino acids and advanced enteral feeding as best you can. That's the only approach. Well, of course, if you're giving catecholamines or steroids, you might get rid of those as best you can. But certainly advancing both parenteral and enteral protein and amino acids nutrition will be the most valuable.
Is there a test to determine if the infant is catabolic on a lower GIR, or is the catabolic state more determined by the blood glucose level?
These babies are catabolic anyway. I don't know that any measure of catabolism is available at in the clinical setting at the bedside. People have looked at things, nutritional items like transthyretin or BUN, but for the most part, if the baby's hyperglycemic and has a variety of illnesses and physiological disturbances and therapeutic problems, you can just assume the baby's catabolic.
All right. It looks like we've taken care of all of the questions that have been asked, and we're just about, oh, sorry, one more came in. Is there a clinical measure of oxidative stress due to hyperglycemia?
Well, you could look at a variety of those plasma proteins that I showed. There's a whole bunch of them. Many people are looking at IL-6 or TNF-alpha as inflammatory products of reactive oxygen species production. But I think you could simply state, I could simply state that the higher the glucose, the more likely that's going on.
All right, great. Well, thank you so much, Dr. Hay, for all your insights. Really appreciate it. We hope you all come back and see us on May 13th for Dr. Henry Lee's presentation, and have a great day. Thanks a lot.